I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Greetings and welcome to the December 2018 edition of the PRS Monthly Journal Club podcast. I'm Nicole Phillips, resident ambassador from the Harvard Plastic Surgery Program, and I am joined for this podcast, as I have been throughout the year, by my co-resident ambassadors, Francesco Egro from the University of Pittsburgh and Ira Savetsky from NYU. This will be the last podcast we record together in these roles, and so I wanted to take a quick moment to thank the PRS team for this amazing opportunity. Ira and Francesco, I'm truly grateful to have worked so closely with you both this year, and I look forward to our future collaborations. Our guest moderator for today's podcast is Dr. Justine Lee. Dr. Lee is the Bernard G. Sarnat Endowed Chair for Craniofacial Biology and Associate Professor at the UCLA Division of Plastic and Reconstructive Surgery. On a personal note, I looked up to Dr. Lee when she was a resident at the University of Chicago, and I was a medical student just beginning to pursue my interest in plastic surgery, so it's a particular honor for me to welcome her here today. Dr. Lee, thank you so much for joining us.
Thank you so much for having me.
Before we begin, I'd like to remind our listeners that this article, along with every PRS Journal Club article, is available for free on the PRS website, along with selected article pairings and related video content. So go ahead and check out the section online as a great supplement to today's podcast. The article we will be discussing is entitled, Can Functional Nasal Surgery Treat Chronic Headaches? A Systematic Review, by authors Rebecca Farmer, Ravi Garg, and Ahmed Afifi from the University of Wisconsin-Madison. As initially described by Gyron, multiple trigger sites have been delineated in the head and neck, theorized to contribute to migraine and other headache symptomatology. These trigger sites are the target of the surgical techniques which have evolved for the management of chronic headaches. While abnormal nasal mucosal contact points have been suggested as trigger sites, and multiple studies have examined different means of addressing these contact points, no systematic review has previously examined the efficacy of functional nasal surgery as a treatment for headaches. This study is a systematic literature review designed to answer this question. 39 studies met inclusion criteria for a total of 1,577 patients who underwent functional nasal surgery for treatment of headaches. Septoplasty and/or turbinate reduction was performed in all studies, with endoscopic sinus surgery also involved in 18 of the 39. Reviewing outcomes for all patients, 48% reported cure in their headaches after surgery, 37% reported significant improvement in either severity or frequency of headache symptoms, and 15% reported no change in symptoms. Now, recognizing that endoscopic sinus surgery could certainly be a complicating factor, since underlying sinus disease can contribute to chronic headaches, the authors studied the subgroup of patients who underwent functional nasal surgery without endoscopic sinus surgery. Among this patient population, 45% reported complete cure, 41% reported partial resolution of symptoms, and 14% were unchanged. While these numbers are impressive and seem to be in keeping with the overall findings, there was a statistically significant difference when compared to patients who underwent endoscopic sinus surgery as part of their procedure, with a higher percentage of those patients reporting complete or partial relief. While not every study included outcome data, such as change in visual analog score or number of headache days that patients experienced per month, these outcomes were also examined among the papers that did include this data, and statistically significant differences were found between preoperative and postoperative reports, further supporting the theory that functional nasal surgery can improve chronic headache symptoms. Finally, a subgroup analysis was also performed, looking at whether patients had a positive response to a preoperative local anesthetic test. This common diagnostic test for nasal point contact headache was found to be a statistically significant predictor of postoperative success rates. Overall, I think the authors do a great job in assessing the potential pitfalls and weaknesses of their analysis. The majority of studies included in the systematic review are retrospective chart reviews or case series, with only 2 randomized control trials identified. The surgical procedure itself was not standardized, and the addition of endoscopic sinus surgery in multiple studies is certainly a complicating factor. The types of symptoms addressed varied between studies, as did outcome measurements. One of the most interesting discussion points, I think, was regarding the association between obstructed nasal breathing, OSA, and headache symptoms, calling into question the mechanism by which functional nasal surgery addresses chronic headaches. Does improved breathing have a direct impact upon headache symptoms regardless of nasal mucosal contact points, or is the interaction of downstream effects more complex than that? So Dr. Lee, I'm wondering where and how we move forward from here. I thought this was a really interesting study, pointing the way forward in an area of a lot of interest within plastic surgery. But this particular question strikes me as a multidisciplinary problem. And I'd love to hear your thoughts on how we could and should build the ideal team to study this question. Should we involve otolaryngology and neurology directly in these studies? And since I can imagine that some people would say, well, working with otolaryngology may be a conflict of interest, who gets to do the surgeries, who does which part of the surgeries, I'm also wondering how we balance negotiating quote-unquote turf wars with optimizing outcomes for patients.
Nikki, thank you so much for an outstanding summary of this paper and really highlighting the salient points of the paper. I think you highlighted exactly the thoughts that I had while going through the paper. I think the paper is very, very interesting. We do know now that there are anatomical reasons for pain. It's not just some amorphous, unknown thing that occurs and that can be treated systemically with medicine sometimes. Sometimes there's an actual point of contact, whether it be these nasal mucosal contacts as they talk about, or things like compression of nerves that results in pain. And so in that sense, I really like this paper. I really like how they really went in depth and took out the factors of ESS, took out the potential factors of like, what if you sprayed some lidocaine up there and nothing happened, and we're able to parse that out. I think where we go from here is it definitely needs to be explored in greater detail. So before we really get into completely figuring out the best way to care for these patients, we need to actually know, how do we truly identify these patients, and if we were to randomize them in a way that is ethical, would we see the same effects? And after we get to that point where we do have definitive proof that there is no doubt about this and it is not due to various other reasons, as the authors have alluded to, then we can really start thinking about, who's going to be on board with this? Is neurology going to be on board if they're shown the data and the data is specifically anatomical issues? Are they going to be on board? Are they going to believe that this is the way that you could potentially treat some headaches? And otolaryngology, I suspect that as time goes on, and if the data is there and the data is good, we're not going to be operating any different than we are now. There will be otolaryngologists doing this surgery for this indication, and there will also be plastic surgeons doing the same thing.
Thanks so much. I think it's a really great point to highlight, that we need to first delineate the problem and really make sure we understand it before we move forward. So thank you so much for bringing that up. Ira, what were your thoughts about this paper?
I thought this was a really interesting study. I find it interesting, it's not something I thought of going into this field, that we as plastic surgeons have sort of this ability to potentially cure people with migraines or quote-unquote migraines or headaches. And I witnessed this firsthand last year when I was able to participate in one of these occipital nerve decompressions in a young woman who's been on significant opioids, and after the decompression she was essentially cured. So it's pretty amazing, our role in this. And I think, as we sort of alluded to already, some part of the challenge is convincing, or at least showing the data to other physicians, such as you mentioned, as whether it be neurologists. And it, in general, to my knowledge, they're overall, at least in specific institution, there's still a lot of skepticism and hesitation surrounding some of these procedures. And I'm just curious, Dr. Lee, and we sort of touched on it a little bit, but what are some of the ways we could sort of better integrate these patients into our practice? Should we be going to conferences dedicated to neurology or otolaryngology? Should we be showing them the data and explain to them and give them a better understanding of the pathophysiology in these cases?
I think there's a multiple part answer to that. With a neurologist, they are of a completely different discipline than us. They don't see what we frequently see in the operating room. When you see a compressed nerve and you see what it looks like when you decompress it, they've never seen that before. So for them to kind of be able to even conceptualize the fact that this is a truly anatomic problem, in certain cases, not all cases, but in certain cases, truly anatomic problem that is then altering whatever molecular mechanisms that are causing the sensation of pain, is something that we could probably do a better job at helping them understand with more conversation and potentially more discussions with their group, showing them what we see in the operating room. It's quite dramatic, as you know. I mean, sometimes you just see it, and from hand surgery and et cetera, you see what decompression looks like. Now, the other part, when it comes to otolaryngologists, I think they would be quick adopters. If the data is there, I'm sure they would be very much on board, and I don't think they would take much convincing at all. But in terms of building a clinical practice and trying to help these patients more so, I would say that probably the best way to do that is to have discussions with the neurologists and also the pain doctors. I think the anesthesiologists would be very open to that. They might want to do it at some point, but they'd be very open to that.
Yeah, and I agree with you certainly that otolaryngology and anesthesia would certainly be quicker to adapt that. Francesco, what are some of your thoughts of this paper?
Thanks, Ira. I'll start by saying that I agree with everything that has been said so far. I thought this overall was a really interesting article and certainly well-conducted systematic review. But I must admit, I might play devil's advocate here. I could not stop thinking while reading this paper of whether as plastic surgeons we should be embarking into nasal mucosa surgery on a routine basis that could potentially alter the nasal airflow and potentially have problems that would be hard to reverse. Would functional nasal surgery be better managed by ENT or perhaps at least in conjunction with ENT? I know that with rhinoplasties and so on, we do alter not only the aesthetics but sometimes also the function of the nose. But I wanted to hear your thoughts, Dr. Lee. What do you think?
The truth is we've been doing it forever. So it's not anything new. And I think that both otolaryngologists as well as plastic surgeons who are well versed in rhinoplasty frequently do a lot of functional rhinoplasty. Even if their practice is primarily aesthetic, there's a lot of functional issues that are being addressed at the same time. Because obviously, if you were to address, say, for example, an aesthetic issue, would you just not do the functional issue and leave the patient with breathing issues? You wouldn't. You would definitely address that. And whether you address it with an otolaryngologist or yourself is definitely under the purview of the surgeon's preference. I think I've seen it both ways. I've seen some do it in conjunction with otolaryngology, but frankly, I think the reasoning for that is they're frequently the referring physicians. Usually the sinus surgeons are frequently the referring physicians. Now, I've seen plenty of us in craniofacial surgery as well as not craniofacial surgery do functional rhinoplasties and do an excellent job. I think the concepts of working on the nose have been very well defined over the course of the years, even if there are arguments of which way is the best way, but the concepts are well defined at this point in time.
I think that's a great discussion point, kind of keeping in mind that we're already doing these multidisciplinary surgeries a lot of the time, as you mentioned, for, either for referral pattern reasons or elsewise. So certainly the collaboration mechanism has been set in place for us already, which is wonderful. Well, with that, I think we will wrap up our discussion on this article. I would like to thank Dr. Lee and my co-resident ambassadors for another great conversation. I've really enjoyed it. I hope our listeners have as well. Before we go, I'd like to remind our listeners to tune into the other two December 2018 PRS Journal Club podcasts. If you like what you hear, please share us with your colleagues and rate us in the Apple iTunes Store. Make sure to visit and like our PRS Facebook page, and don't miss the monthly PRS Facebook Journal Club, where you can interact with each month's featured authors in real time. And thank you again, Dr. Lee, for joining us.
You're welcome. Thanks for having me.